morning, and thank you for joining us for today's vertical integration session, a bite-sized introduction to public health with Dr. Kat Taylor and Dr. Richard Broom. My name is Sydney, and I'm from the PHN education team. Before we begin, I'd like to acknowledge the traditional custodians of the land that we live and work on. For myself on the Central Coast, that is Darkinjung land, and I'd also like to pay respect to all elders past, present, and emerging. Now, a few things to let you know about the session. It is being recorded and will be available for you to view in our library in a few days' time, as well as a copy of the PowerPoint PDF slides. Now, as attendees, we encourage you to interact as much as you can. Please pop anything you need in the chat, and then at the end, we will do a Q&A. At the end, I'll also put the link to the Slido evaluation. Please, your feedback is extremely important as it enables us to provide this future education. Now it is my great pleasure to hand it over to Dr. Kat Taylor, Dr. Richard Broom.
Thanks, Sydney, for that very warm welcome. Can you hear us okay? Excellent. So hi, everyone. For those of you that don't know me, I'm Dr. Kat Taylor, the Director of the Central Coast Public Health Unit, and I'm joined by my trusty offsider, Dr. Richard Broom, who's our wonderful public health staff specialist. Richard, did you want to say a quick hi?
Hi. I've met a few of you already, actually, which is nice. But nice to meet you all.
Excellent. So yeah, we were delighted when Georgia invited us to come and do this session for you, and we were sort of spitballing some topics, and things like travel medicine came up and a few bits and pieces. So we thought we'd just share a smattering, a tasting plate, if you will, and noting that there's been some quite topical activity lately relating to rabies and Australian bat lizarvirus. We thought we'd include a bit of a focus on that. But we'll keep it very informal. Feel free to pop your hands up, ask questions, interrupt, and Richard and I will just kind of take you on this little tour. So by the end of this activity, we hope that you'll be able to describe conditions which are notifiable, so medically notifiable under the Public Health Act, and how to notify. Discuss the key risks associated with short-term international trips with patients, and to also obviously keep these risks in the back of your mind when assessing return travellers. And lastly, to manage and counsel patients presenting for post-exposure assessment and management if they've had a potential rabies-prone exposure. And I would also like to acknowledge the beautiful Darkinjung country on which we are meeting. So quick public health. What is public health? It's a many-headed beast. The lovely WHO definition is that it's the art and science of preventing disease, prolonging life, and promoting health through the organised efforts of society. So it's very kind of governmental function. But yeah, essentially there are, I think, 15 public health units across New South Wales. We all function as kind of regional arms of the health department in our local area. So Central Coast has a public health unit. To our north, we've got the Hunter New England Public Health Unit, and obviously we share the PHN. And then to the south, we've got North Sydney Public Health Unit, and we all work together as a network. And I think that network functioned incredibly well over particularly surge responses such as the COVID-19 pandemic. But these are all of the functions that your local public health unit would do. We keep an eye on disease trends, monitoring, analysis, but particularly we focus on public health response to control notifiable conditions. And there's also elements of communication, research, and health promotion in there. So in terms of what that looks like at a more operational level, we have, broadly speaking, three major areas of focus. One is communicable diseases. So there is a whole list of diseases which are notifiable under the Public Health Act 2010, and that's primarily because they are infectious diseases that can be either transmitted from a person to another, or they may be zoonotic infections which can be passed from animals to people. And the reason that they're notifiable is because there are usually measures that can be taken to prevent, detect, and respond to those diseases. And they may also have the potential to cause outbreaks in the community. So we have a mighty communicable diseases team, which is staffed by clinical nurse consultants and a disease surveillance officer. And they handle the notifications on a day-to-day basis. And we have control guidelines that dictate the public health response for those and any measures that need to be taken for relevant contacts of those conditions. So these are just a couple of the recent-ish things that have made headlines for public health for communicable disease. We also have an environmental health section. So environmental health officers who are, have a range of regulatory powers under the Public Health Act and various other New South Wales instruments, and concerned with anything environmentally that might impact on the health of the population, which when you think about it is quite a lot of things. Things that we often take for granted, such as drinking water quality. You might recall the boil water alert that was issued for Terrigal and some surrounding suburbs earlier this year. So that was our environmental health section, working closely to support council, the water utility, in the provision of safe drinking water. And then there's a whole bunch of other things there. I won't go through the full list, but just to give a bit of an idea of the diversity of things that the environmental health team deals with. And we also have a wonderful immunisation section who many of you would have dealt with, or your practice staff and nurses. So our immunisation nurses are responsible for the provision of technical advice and support to all the immunisation providers across the LHD. So this is anything pertaining to, catch-up vaccination advice, advice about cold chain breaches or incidents or maintenance, any adverse events following immunisation, which are required to be notified to the TGA, so we can support you with those notifications as well. And more recently, we've made a bit of a foray into the provision of opportunistic and outreach immunisation services across the district. So that's been an exciting piece of work over the past few years. But yes, coming back to notifiable diseases, you're probably aware, I'm not sure how many students we have on here, but you're probably aware that there are a range of conditions which are actually enshrined in law as a requirement to notify under the Public Health Act 2010. And there are different responsibilities depending on your place in the system. So doctors are responsible for notifying a number of these diseases. Laboratories are also responsible for notifying when they make diagnoses in the lab. And hospitals, or technically hospital CEOs, are responsible for notifying, but that's often their delegate, which may be the ED staff specialist who needs to notify diseases, often on clinical suspicion on presentation to ED. But for the purpose of this talk, we're looking at the doctor notifiable form. There is a form on the website, which I will include in the slides when they get issued. But yes, if you just Google, New South Wales notifiable diseases, you'll easily get to these links. And there is a reasonably short list of things which we want you to pick up the phone to us about. And probably the notable ones here are measles. So that's been fairly topical this year. And we'll talk a little bit more about that later in the talk. But also some other ones that you might not be aware that you need to call us about of foodborne illness. So we have actually been notified of some, suspected foodborne disease outbreaks from astute clinicians who've called us because they've seen, several patients come in linked to a similar venue. So we really do rely on your frontline surveillance of your patients and knowing what's going on in your local communities to let us know about concerns out there. I mean, other examples that spring to mind are we got a call from a local GP that was concerned about B6 toxicity that she was noting in some of her patients. And so, that we really rely on those astute clinician notifications to identify threats to public health that might warrant further investigation. So that's the list. And then there are also some others which are notifiable by phone or mail. And we often will contact you about these. So there are some forms that we send out for syphilis, for example, if we haven't heard from you. Adverse events following immunisation, that's probably another key one. But yes, so just pick up the phone, and I realise now that I haven't put the number on here, but there's a 1300 number which is geolocated to your local public health unit. So if you're based on the coast, that will come through to us. So the number's 1300 066 055, and we will put that on the slides. Or we have a local number as well, which is 4320 9730. So you can call us anytime. We have a 24/7 on call, and hopefully you won't be seeing patients at midnight though. Okay, so we thought I'll just pause there. Are there any questions before we move on to a bit of a international sojourn? Richard, did you want to add anything? Okay.
Not yet, thank you.
All right, well, we'll push on. So yes, I will make a disclaimer here that I am not a travel medicine practitioner. Many, many moons ago, when I was doing my public health training, and was at that stage a GP, I was moonlighting in a travel medicine clinic down in South Australia, with the wonderful Dr. Bob Cass down in Globe Medical. So I have done some travel medicine, but that was a very long time ago. But we do certainly, as public health people, keep a close eye on international travel and migration patterns, because that does certainly pose a potential risk in terms of the importation and movement of diseases around people. And both Richard and I are also Commonwealth Human Biosecurity Officers, so we have certain functions as well in terms of the control of the international borders. So with that disclaimer, I'll just contextualize this information. We thought that we'd take you on a little holiday. So first of all, where are we going? Well, I mean, you can see here, this is just the overall, this is ABS data looking at overseas arrivals and departures to Australia. You can see that precipitous drop off as the borders were closed in 20th of March 2020, I think it was. And then the return to kind of pre-pandemic or exceeding pre-pandemic levels since they were reopened in 2022. So travel's definitely made a strong comeback, although growth has probably been slightly dampened over the past year by increasing cost of living pressures and I guess a trend towards people not wanting to have as much of a carbon footprint, and so looking at trips closer to home. So in terms of the destinations, this is again quite a busy slide, lots of interesting information on this one. But yes, the top destination remains Indonesia. And so the coloured bars go from 2019, so that's pre-pandemic, and then there's sort of a post-pandemic. So the dark blue is 2023, the orange is 2024, and the maroon, whatever you call it, is 2025. So you can see here that, travel to Indonesia is far outstripping what its pre-pandemic level was. And it remains the top destination for Australians to go for short-term trips. New Zealand remains ever popular, although slight drop-off since pre-pandemic levels. One that seems to have grown substantially is travel to Japan. So you can see that demand for Japan trips has is almost double what it was in the pre-pandemic. And with recent geopolitics, who could blame us? We seem to be going to the US less often. But so those are sort of the main destinations, and some other key ones to look at here are Vietnam, India, and Fiji, which also remain fairly popular destinations. Yes, Richard.
Sorry, Kat, and perhaps you're going to cover this later, but I guess something I just makes me think of with this slide is that different sorts of people are traveling to different places. So one of the big issues we have from a public health point of view is, or not big issues, but I guess focuses is people returning home to see family and friends. So I'm guessing that perhaps that might be the Chinese and Indian groups here, maybe Indonesian, because often those people don't think of themselves as travelers in the same way as tourists, so they might not take the same precautions.
Yeah, that's absolutely right, Richard. Thanks for that. So in terms of travel trends, this is slightly older data, but us Aussies are very adventurous, keen interest in visiting new places, preference for nature-centric experiences, coastal proximity, and exploration of secluded off-the-beaten-track locations. So I suppose that's lovely for us, but there is potentially public health risk associated with that as well. And we also are somewhat last minute in terms of planning, and so there may be limited opportunity or thought given to pre-travel vaccinations or seeking of medical advice. This was just a recent Skyscanner poll from July last year, where go with the weather, food and culture, and also some of those. So word of mouth, social media, and film and TV are the most important sources of travel inspo for 2025. So with that, we thought we'd take you on just a quick little holiday to Bali. So yes, we thought we'd just have a look at some of the inherent public health risks with this very well trodden path by Australians. And we note that, you know, Newcastle's opened up its direct flights again. So where else are you going to go but Bali? So day one, you check into your villa and you take a stroll into downtown Kuta. And I don't know how many here have been to Bali, but there's this wonderful street food called bebek bengil, which is this crispy duck, which you've been told is an absolute must try. And so you find this cute little stall that's manned with a quaint toothless lady waving flies away with a banana leaf. And, you know, you've got to put that one on Insta. Oops, we've given that one away. So we just wanted to see if anyone would like to hazard a guess what you might be putting yourself at risk of by eating from street vendors in Bali. Feel free to shout out or put hands up or jump in. Oh, everyone's still eating their breakfast.
I just put in there non-specifically Bali belly.
Yes.
And then we've also got typhoid, Hep A was another suggestion.
Ah, brilliant. Sorry, I can't see the chat at the moment while I'm
That's okay. Yeah, Salmonella, Campylobacter, other options mentioned.
Yeah. Oh, you guys are all over it. So yes, enteric diseases. So this is probably not what you meant by a water view from your villa, but yeah. So enteric disease is a very real risk for these trips, and we do see many return travellers with this or having their holiday spoiled by this. So yeah, Salmonella typhi is the causative agent of typhoid fever, which primarily comes from contaminated food. But certainly Hep A is another one, which is, you know, not included routinely in our schedule unless you are an Aboriginal person. And so, yeah, acute viral liver infection, which is transmitted by the fecal-oral route or potentially contaminated food or water. And to a lesser extent, cholera. So that is also a risk. And many of these are vaccine preventable. So children aged more than 2 years and adults are recommended to receive a typhoid vaccine if you're travelling to endemic regions. And obviously there's that oral formulation or a parenteral dose, which can come as a combination vaccine with Hep A. And with the cholera vaccine, the oral cholera vaccine may provide some cross protection against traveller's diarrhea that's caused by enteroinvasive E. coli. Yes, Dimity.
Hi, can you hear me okay?
Yes.
I'm having trouble with my computer today. I had a patient who came back from Bali. She's a sort of patient, young person, goes to any local doctor wherever she happens to be, and she said she'd come back. Her husband had got typhoid in Bali, and now she was sick, and now the little one was sick as well. And I organised for stool cultures and things, but I gave her the typhoid public health shed, and talked about not working and stuff, and she was really cross with me. She said the other doctor who talked to her husband and who she'd seen as well on other occasions said there was no need for any of that. So then there was a whole lot of ringing around to public health units and things trying to find out what had happened. And it turned out to be a different sort of salmonella, not Salmonella typhi.
Yes.
And so I'm just telling that story because it took me quite a few days to sort out and really offended the patient. And she had no idea that I wouldn't know what her results were from the other doctor. She was like a last minute traveller who taken the kids there. And also the disease was quite interesting because I didn't realise that typhoid fever doesn't necessarily have huge amounts of diarrhea. It had high temperature and abdo pain and enormous anorexia, and she had all of those things. So it fitted with typhoid, but of course Probably salmonella can do those things too. So it
Yes.
was a big learning experience for our whole practice, actually.
Oh, thanks for sharing that story, Dimity. And yeah, we certainly do see people coming back with invasive salmonellosis that's not typhoid as well. Yeah, I guess there are many things that one can expose oneself to, and you can also contract these infections in, well, not typhoid, but you can certainly contract invasive salmonellosis in Australia. But yeah, it is a challenge with the management of contacts of typhoid. So typically we don't require isolation from work for contacts of confirmed typhoid fever if they're not in a high risk of onward transmission. So that's kind of in occupations like childcare or healthcare work, or of course food handling. But for people that are in that higher risk of onward transmission group, we do require clearance samples of those people. So yeah, but public health is here to guide you through that management process. So hopefully your local PHU that you managed to get in contact with were able to guide you through that.
Yeah. And it was tricky because I was then travelling to Queensland. And the number I had was a generic number. And I kept
Yes.
getting Queensland.
We should put our direct number on as well, shouldn't
I
we?
think it would be helpful, actually. Yeah.
Can I? The other thing that makes me think of, Dimity, is just, I guess, one of our mantras in public health, particularly for contact, is about confirming the diagnosis, because not often, but you're never quite sure until you've got actual microbiological confirmation that people are saying have what they say they have.
Yes.
Yeah, well, of course, the other doctor had done all those tests, but I didn't have access to them. And she wasn't, she wasn't a person who had access to the generic. She'd refused to be my health record person. So, she was a bit tricky, that patient. And then the child was in childcare, and she was working in a deli serving food.
Gosh.
So
Yes.
it was like, okay.
Thanks. Okay, so we'll push on through our trip. So we're on day 4. You've finally recovered enough to go sightseeing, and believing your lonely planet that no trip to Bali is complete without a visit to the Ubud monkey forest, you venture there. And so although you've now learnt your lesson about food safety, you didn't realise that opening a packet of chips could be hazardous until you were swarmed by hungry, shrieking monkeys. So, okay, well, probably no guesses as to the risk that we're talking about here. And I mean, it's not a joking matter. Rabies is unfortunately a cause of 60,000 deaths globally per year. I've said here it's 100% vaccine preventable, but I suppose that is maybe slightly disputed because there are very, very rare instances of vaccine breakthrough or failure. But yes, I mean, in terms of pre-exposure prophylaxis, yes, it is vaccine preventable. And a few doses over the course of a month, will do you for pre-exposure prophylaxis. The post-exposure is somewhat more challenging, and Richard will go through this in more detail with the case studies. But yeah, it's quite a costly and time-consuming affair to try and get human rabies immunoglobulin, particularly whilst you're overseas, and then to complete the course when you return to Australia. So I won't dwell on this because Richard's covering this content. But yes, so the following day, having gotten yourself worked up about potential risks of rabies, you duly take yourself off to the local medical facility, and there they do some wound care, take some bloods, and you get given a single dose of a rabies vaccine because there's no immunoglobulin available. I guess just to highlight here, are there any potential risks of receiving healthcare overseas? And certainly not to say with this particular facility, which is just a little postcard, but any things to be aware of if people are going overseas and having bloods collected, or IV lines put up, or potentially going for medical tourism and having cheap dental work done.
Yeah, so hepatitis B and also other blood-borne diseases as well.
Yeah, absolutely. I'm not sure what's happening with that medical tourism trend anymore, but yes, but certainly Hep B is a consideration. We do have sort of universal infant coverage now, which has been rolled out since 2000. But, middle-aged adults may not necessarily be covered. And so that's potentially a consideration when your patients may be travelling overseas and thinking about pre-travel vaccines if they haven't had a course of Hep B. Okay, well, we're on day 6 of the holiday and we're heading back already. It hasn't been much of a holiday. You've spent most of it sitting on the toilet. You've had to fork out hundreds for medical treatments because you didn't take out travel insurance. And now you have to figure out how to complete your suboptimal rabies post-exposure prophylaxis course when you get home. You've just gotten unpacked on the Sunday when suddenly your phone pings. It's a text message from New South Wales Health saying there was a person with infectious measles on your flight. And now you have to try and work out whether your mum still has your vaccination records and monitor yourself for symptoms for 2 weeks. And if you're not immune, you might have to rush to get vaccinated, and good luck with that on a Sunday. So, yes, we did have our first case of measles in 6 years back in February of this year. In a young person who was not vaccinated and brought it back from a trip to Southeast Asia. So as we know, it's a highly infectious viral illness. Vaccination can be effective as post-exposure prophylaxis, but vaccination is also highly effective if received as a 2-dose course. And just highlighting that, there's this cohort born kind of between when natural immunity or, having had this routinely as a child occurred prior to 1966, and prior to the introduction of a 2-dose schedule in 1975. So there are people in this kind of cohort that may have either had 1 dose or no doses and not be protected through natural immunity. Sorry, Richard, did you have your hand up?
Did question for you, Kat. Sorry to put you. How quickly do you need your post-exposure vaccine to be effective? Is it
within 72 hours?
72 hours, yeah. Just so it is time critical.
Yes. Yeah, so there are some wonderful vaccines that can stimulate an immune response prior to the disease itself taking hold in the body. So rabies is one of those things, and measles is another of those things, because the incubation period for measles virus is quite long. So yes, the theory behind post-exposure prophylaxis is the sooner you get it in, the better, to help your body mount a quicker response and fend off the disease. Sorry, this is a bit of an older slide, but just showing that kind of global slip in, unfortunately, childhood vaccination. And yeah, this is numbers of 0-dose children in the red here, which is quite concerning. And there has been some recovery in those numbers, but you can see that in some of our very near neighbours, and we see this playing out with a global surge in resurgence in measles. And, we've even seen that in settings like the US, quite tragically. And that's what it looks like in New South Wales. So haven't had I think there's been maybe one in the last little while. There was quite a lot of activity in January, and we were a bit concerned because, those alerts were coming out every other day with the different exposure locations. But yes, we remain vigilant for it, and hopefully we're able to maintain sufficient public health response as well as childhood vaccination coverage to make sure that we don't get established local transmission back in Australia. Okay, so Monday morning, you're all ready to go back to work after your holiday, and then this happens. So wouldn't be a public health talk without a bit on COVID. Fortunately, locally, COVID appears to have peaked. So this is our local acute respiratory illness chart, which shows COVID in the blue, respiratory syncytial virus in the green, and influenza in the red. And so COVID has peaked and will continue to decline. There is a new variant circulating, which is called XFG. And the increase of that variant may be slightly slowing the rate of decline of the Nimbus wave that we've just been through, but it is expected to continue to decrease. But unfortunately, all is flu at the moment, as I'm sure you're experiencing out there, and flu activity is projected to continue to increase over the next month. So we're still not out of the woods, and influenza A and B are contributing to that. So I think that was all from me. Oh, hang on. Maybe I've got, yes, that was it. Okay, Richard, over to you. Oh, you're muted.
Thanks. Yeah, no, thank you. And I'm going to actually try and take control of the screen because I think having a cursor might be handy with some of my slides. So just bear with me. Can I just check? Are you getting, oh, is that working?
Yep, I've got the title page.
Yeah, okay. Yeah, of course it's mine, isn't it? Not yours. Oh, sorry, everybody. I've just got to, it's going very slowly. Sorry. Here we go. We're off.
So while you're doing that, Diana's asked a question about recommending a second flu shot during the season. It is a controversial question, and I know that there were some schools of thought, particularly for older adults who might not mount as robust or as prolonged an immune response. It was thought to potentially have 2 flu shots during the season, but no, the current recommendation is just to have that single flu shot during the season. And yes, there'll be lots of theories about the timing of that in the season, but it's kind of like trying to catch a falling knife. Probably the best time to get vaccinated is when, as soon as you can. Thanks, Diana.
Okay, so look, thanks everybody. So my intention here is just to talk a bit more about prevention of rabies and ABLV, and obviously it's been quite topical with the recent case that Kat mentioned. But also it's a very common call that we get here at the Public Health Unit. I kind of have this, I envisage GP surgeries all over the coast full of people who've been to the monkey forest, which I think is probably not quite true, but it's certainly something we get almost weekly or every other week a call about someone who's been exposed to rabies. So it's pretty common, and it's a bit complicated as well, I think, understanding pre and post exposure prophylaxis. So my intention here is really just to take you largely through what the Australian Immunisation Handbook says we should be doing, because I think that's the best resource that we have locally. So so rabies actually is I think mainly the term to describe the clinical syndrome that you get when you become infected with a lyssavirus of some description. And rabies virus, the actual classic rabies virus, is caused by dog bites primarily. About 99% of all human cases are dog bite related. And as Kat says, there's probably at least 60,000 cases annually, but we reckon it's fairly underreported, and most of those cases are in Africa or Asia. So and often in much less developed parts of the world. So the number is probably quite a bit larger than that. And it's maybe not 100% completely, as Kat said, but pretty a very preventable illness, particularly if you get timely post-exposure treatment. And it's not one virus. There's a bunch, but the ones I guess there's the classic rabies virus, RABV, and the one that we're interested in locally as well, which is ABLV, but there's also a European bat lyssavirus and these other 2 viruses that I hadn't heard of until I was preparing this talk. I think Urkut is you get from bats in East Asia, and Mucola terrestrial animals in Africa, I believe, but I suspect we won't see much of that locally. And this is just, this is a Balinese dog. We know that Balinese dogs do have rabies. That was discovered in 2008. Prior to that, we thought that Bali was rabies free. And here's somebody, this actually isn't the Bali monkey, the Ubud monkey forest. Apparently there's another monkey forest that's much better, according to Instagram. That's this one, but I'm sure the monkeys are equally fierce. So this is just the reason I guess it's become topical, or one of the reasons. So I'm sure most of you will have certainly heard about the poor person who died on the north coast of New South Wales after being scratched by a bat, or actually bitten. I think it was a fairly deep bite, I understand, to his finger. And I guess the interesting thing about this person was that he did receive a full course of post-exposure treatment after his bite in accordance with the guidelines. As we understand it, he received his rig 48 or just under 48 hours after, as I think about 40 hours it was, just after his exposure, which is consistent with the guidelines that say 48 hours. But to me, it highlights the need to try and get post-exposure treatment into people as soon as you reasonably can. But we'll talk a bit more about that later. But the other story you may not have heard about, I guess, which is also interesting, was a British woman who died in June, I think. Who was scratched by a puppy in Morocco about 6 months earlier at the beginning of the year and didn't think anything more about it, so didn't get any treatment, and then obviously developed rabies 6 months later. So that's caused a big stir in the UK, and actually I think it's resulted in there being a bit of a shortage of rig in the UK. So they've issued some updated guidelines about that, which is quite interesting. And that is one of the challenges, I think, with rabies, and why post-exposure, one of the reasons we have public health is involved in post-exposure treatment is just controlling the stock of the treatments, which are slightly scarce. Just to give you a bit more background about Australian bat lyssavirus. So a while ago, there were surveys which estimated that there was a prevalence in bats of less than 1%. And since then, there haven't been any of those tests recently, but there is kind of opportunistic testing of bats, which when they're found dead, or people pick them up when their cats bring them in from the garden, and in those testing, in that sort of testing, there's been 8 cases reported in 2024, which was about getting on for 2% of the bats. But obviously, the thing about those bats is they're probably Hey everyone, can I check? I lost you all.
We lost you too, Richard.
Yeah, you're there. Okay, yeah, I'm back again. So sorry about that. My internet or something just dropped out, I think. I'll just start again. Okay, can I just check you can see the slide?
Perfect.
Okay, great. So moving swiftly on. So I think I was just saying that the prevalence is probably around about something under 1% in Australian bats. And there's been 4 human cases of ABLV that we know of. 3 were in Queensland over the sort of end of the last century, beginning of early 2000s, and then 1 obviously this year in New South Wales. So I won't dwell on this, but I'm sure most of you are fairly familiar with the idea. Rabies is passed on through the saliva of an infected animal.
Oh dear, have we lost Richard again?
We've lost you again, Richard.
Okay, maybe I should keep talking. See another question from Diana about rabies prophylactically for short trips to at-risk countries, or per the immunisation handbook if prolonged trip as advised, an increase in risk. Oh, thanks.
Yeah, you're back. Sorry, this is you can hear me, see the screen?
Yes.
Okay, great. Sorry, everybody. Shall I press on?
Oh, I was just quickly addressing Diana's question in the chat about rabies prophylactically for short trips. I think one of the considerations is how readily will they be able to access post-exposure prophylaxis, and what's the likelihood that they'll have any kind of contact. And in a scenario like Bali, it can be very difficult to prevent or predict that, particularly as well if you're a small child. So I think there's a few things that would factor into the decision. But yes, I mean, I think if there's any potential risk that they might encounter a rabies exposure, that can happen irrespective of the duration of the trip. It is certainly worth thinking about the course of pre-exposure prophylaxis.
And I'll talk a little bit more about that as well in just a sec. So as you're talking about now, so pre-exposure prophylaxis is recommended for people who may get bitten or scratched when they're through their work. So things like bat handlers, vets, wildlife officers, wires workers, laboratory workers who work with lyssaviruses. I suspect they'll be dealt with by their employers, but they're a very high risk group, and I don't think there's many of those people in Australia. But obviously, this is the one that we're just talking about now. So people who are travelling, and what the guidelines say is, give pre-exposure prophylaxis after a risk assessment, and it's not a very helpful guidance, but I'll talk a bit more about that in the moment. But the main reason I think, so pre-exposure prophylaxis is good, and I think, but the main benefit of it is from the person's point of view that if they do have it, they'll require a shortened course of post-exposure treatment if they are exposed, and generally speaking, they won't need RIG, but that's not universally the case. If they're severely immunocompromised, they'd still need RIG. So I think the main point is that if you're, especially in a place where you don't necessarily trust the blood products, you reduce the likelihood of needing RIG if you do get exposed to rabies. But you still do, if you get bitten, even after pre-exposure treatment, if you get bitten, you still need to seek medical advice. So this is the guidance that we have. So risk assessment should consider the likelihood of interacting with animals and access to medical attention. So I guess for me, the question, people are saying, well, I'm going to have an interaction with animals because I'm a wildlife, a zoo worker or something like that who's going on a trip overseas. Then obviously it's easy to say rabies vaccination is required. I think it's harder when we know that people do go to visit the monkey forest, and all those people seem to end up needing post-exposure treatment, what to say. But the other factor is whether when you're there, you can seek medical advice or you can get reasonable medical attention and in a timely way, and how long you're there for as well. So I think if you're going to be in a country for a long time, that increases the chance of you being exposed to animals. And it also means that you're less likely to be able to seek medical treatment when you get home as well. So I think probably the main groups are people are going to see animals, and people who are going to be in a country for a long time where medical services may not be 100% or may not be as good as they are in Australia, I suppose. Those would be the two groups I'd be focusing on. But the other thing is just to give people good advice as well before they go, which is about avoiding animals. Again, these are the tips from the immunization handbook. It's important children are at greater risk and they're more likely to get bites on their heads because of their size. So it's important that people take good care of their children. There's special Balinese monkey forest advice in the immunization handbook as well about not feeding or patting monkeys. But the other thing to do is to warn people that if they do get bitten, that they need to seek medical advice and to implement first aid as well. So just general good travel tips. One of the things that's not entirely straightforward is just knowing what the risk is in other countries. So the CDNA here in Australia recommends using the UK list, which you've got a link to here. It just gives you fairly up-to-date information about the risk in animals. Importantly, bats are a risk in every country. So if you see someone who's had contact with a bat, you have to consider rabies no matter where they were. And the vaccine schedule it's a 3-dose schedule. The recommended schedule is 3 doses, I should say, days 0, 7, and 21. IM is the preferred route, although you can give an intradermal course as well. But I've said here, seek expert advice. It's a little bit complicated. So I think before you embarked on that, I'd suggest talking to us perhaps, or the NCAs. And I don't quite know why you would do that locally. The reason I think for doing an intradermal course would be to spare vaccine. So basically, I think IM is almost certainly what most people would be doing. There is also a 2-dose schedule, which doesn't provide such long protection, but that may be useful in people who don't come to you sufficiently far in advance of their trip. And everyone who has a 2-dose schedule will need a booster at a year. And it also shouldn't be used for people who are immunocompromised. And I'll just talk about booster doses. So essentially, people who need ongoing exposure do need boosters. And again, even boosters are not entirely straightforward. So taking out the laboratory staff, everybody who has ongoing exposure should have a booster after a year. And then subsequent to that, they should have serological testing. And if they don't have enough antibodies, they'll need further boosters later on. I think that's the basic principle. Everyone gets a booster after a year, serology then every 3 years after that, and then more boosters based on that. Anyone know?
Oh dear.
Treatment side of things. So I guess the 3 key messages: wound care, never forget about wound care. I think we often think just about the vaccination and RIG, but wound care is very important. Risk assessment, and then, as I said here, the other key thing is please always just talk to us. We like getting these calls, and we see it quite a lot. So I feel it's sort of we can help you with the basic process. But wound care is wash for at least 15 minutes and as soon as possible. Apply a virucidal antiseptic that contains either iodine or alcohol. I think one very important thing is, if you can possibly avoid it, the wound shouldn't be sutured. And if it does have to be sutured, it should only be after HRIG is administered, if it was indicated. If people get exposed in their mucous membranes, eyes or mouth, for example, then it should just be flushed with copious amounts of water. And don't forget that they might be at risk of other infections as well. So consider tetanus and other prophylactic antibiotics for appropriate to the wound. So then the next step is to assess the risk and the need for further post-exposure prophylaxis, which is, I guess there's kind of 3 components to that. Like, how likely is it the animal has rabies, which is what sort of animal it is and what country it was in, where the injury was. So injuries on the head and neck and hands are at higher risk, I think, essentially because there's more innovation in those areas, and also the person's level of immunocompromise, which determines something about the type of post-exposure treatment they need. So I'm just trying to look at the chat at the same time. I'll hopefully deal with that question in just a second. And then, yeah, call us, and we deal with this a lot, so we're pretty reasonably, but I think we can certainly help with risk assessment. And also, importantly, the other thing we can do is help you get hold of the vaccine and the human rabies immunoglobulin. One thing I'll just mention at the moment in terms of sourcing vaccine, at the moment on the coast, or for the last 6 months or so, we've had a pre-deployed supply of vaccine at Long Jetty Urgent Care Centre. So that can be quite a good way of getting vaccine to people, particularly if they're, just out of hours and at weekends. We don't yet have a source of RIG, so but we're hoping that we might be able to get some of that locally as well. But that's a work in progress. So post-exposure prophylaxis. So this is the sort of the RIG and vaccine side of things. So there's two different flowcharts that you'll see if you go to the immunization handbook. There's the terrestrial animal one and the bat one. So essentially, for the terrestrial animal one, there's 3 categories of injury. And the 2 that we're interested in, I guess, from a post-exposure, are whether they're in category 2 or 3. And category 2 is sort of very minor injuries, perhaps some nibbling of skin or perhaps a scratch, but with no obvious bleeding. And the category 3 is a fairly obvious bite or an obvious scratch, I would say. And then for the non-immune people, if they're category 2, they don't require RIG, but they do require vaccine. And the post-exposure vaccination course is for immunocompetent people, is 4 doses on days 0, 3, 7, and 14. But for the immunocompromised, they require a 5th dose on day 28. And immunocompromised people also require RIG. Anyone with a category 3 bite who's non-immune requires RIG as well. And I think this is the sort of thing, I'm afraid, if you don't do this regularly, you have to look at the handbook and go through the flow chart to keep abreast of it, because it is a bit confusing. But essentially, if you're immunized, RIG is not indicated, even if you have a category 3 bite, unless you're immunocompromised, and you only require a 2-dose course of vaccine, again, unless you're immunocompromised. So that's the key thing. I've put one caveat here, which is sometimes relevant because people don't present until they get home from their holiday, for example, or they get home from visiting their family. And occasionally we can get away without doing post-exposure prophylaxis because they know that the dog was a family pet or something like that, and they can be very confident that the pet was still healthy 15 days after the exposure, in which case, if that happens, you can get away without giving them prophylaxis. Now, bats. Bats are a bit different. And the issue with bats is that, first of all, the wounds are hard to see. So you can be scratched or bitten without really knowing it because they've got such tiny claws or teeth. And secondly, it seems that superficial wounds are actually riskier than they are with adults. And basically, that means there's only 2 categories of bats. And I mean, to put this in a straightforward way, anyone who has direct physical contact with a bat, basically touches a bat, requires post-exposure prophylaxis. And again, for those people, the post-exposure prophylaxis is basically the same as it was for dogs, so I won't dwell on it. But essentially, there's a much lower threshold for administering post-exposure prophylaxis for people who've had contact with bats, which I guess is particularly relevant given that that is not an uncommon thing to happen here in Australia. And you don't need to see a scratch or a wound. If they've touched the bat without wearing appropriate PPE, that is sufficient reason to give them treatment. And then just a little bit more about the specifics. I've said this already, but I probably confused you. But essentially, post-exposure vaccination for people who are non-immune is 4 doses on day 3, 0, 3, 7, and 14. Importantly, the vaccine must go into the deltoid. If you give it, the immunogenicity doesn't seem to be so good if it goes into other muscles like the gluteal muscles. You mustn't shorten the intervals. If you can't stick to the schedule, you should extend the intervals. That's important. The schedule is important. It doesn't matter how long after the person has been exposed. If they come and they say, you know, a year and a half ago I was bitten by a dog in Bali, for example, and they have a good story, then they should get post-exposure treatment with vaccination. And the other thing is, I'll sort of say this twice, but the other important thing is if HRIG is being administered, it's really important that the vaccine is given into an area away. So usually the contralateral limb, if it's a hand, for example, but given in an area away from where you gave the HRIG, because you don't want the HRIG to interfere with the vaccination response. And then for HRIG, it's indicated, as I said, for category 2 and 3 injuries, which is basically bites or scratches from terrestrial animals or any contact with a bat. And what HRIG is doing is providing a local antibody response whilst the person's responding to vaccination. The dose, and I guess the relevant part of this is the dose is 20 units per kilo, which usually adds up to several mils. And so you want to get as much of that as you can in around the wound itself, but especially, you know, in fingers and things that can be a bit tricky, particularly for children. So if you do have any left over, that should go IM into a muscle, and often the lateral thigh is a good spot for that because that doesn't then interfere so much with where you might want to vaccinate them later. So I think those are the key things with the RIG, but often it is really important to infiltrate as much around the wound as possible. And obviously in fingers, you do have to be a bit careful of compartment syndrome and things, so you should do it slowly. And and sometimes we do see people requiring ring blocks and things to be able to do it adequately, but it is really important that it goes in around the wound. It's something we do see errors around that from time to time. So that's why I'm dwelling on it. And then just finally, I guess the key message, there's a lot there. And I think if you're not seeing this regularly, it's a bit confusing and it's easy to make mistakes. So the key messages are really just to try and recognize that there is a risk for anyone who's had contact or an injury from a terrestrial animal in rabies enzootic countries, but bats as well, anywhere, particularly locally. That's okay, not uncommon. And please feel free to contact us as soon as you do see people who are at risk. We like to get those calls, and also feel free to contact us about pre-exposure questions, all those sorts of things, because it is quite complicated trying to navigate the vaccination schedules for people. So that is it from me. Be keen to hear if you have any questions or experiences that you'd like to share with us.
Yeah, there's a few questions there. Someone had, Alicia has commented, if someone had the three dose course for rabies, say 20 years ago, and they're travelling to a high risk area, do they need another full course for pre-exposure?
Look, so I think I would probably seek advice specifically, but if you were to ask me off the top of my head, I would say I think they would probably get away with one further dose followed by serological testing if there was time. I think that would probably do it.
I think you could, I mean, again, it's really a risk if they become exposed. And so, you know, the algorithm has if PEP was completed more or less than 3 months ago as the cutoff, but they've effectively had a primary course. So if they get exposed, they could just have the post-exposure. I mean, boosters are more for people that have ongoing occupational exposure.
And then you don't ask, should we be recommending rabies prophylactically for short trips? So I know I have patients that are saying, oh, we're off to Bali next week, and you're like, oh, have you had your Hep A? Have you had your typhoid? Should we be throwing rabies vaccines out there as well? And I suppose on another note, like cholera is something I haven't necessarily been recommending for Bali, just because it's hard enough to get the Hep A and typhoid into them.
So look, I don't think it's, unless you know they're going to be having interactions with animals, you know, that's the reason they're going, or there's something that puts them in that category. I don't think for short trips it's something you should be necessarily recommending. I mean, one of the main downside, I think, to pre-exposure treatment is the cost, because I googled it. Actually, Chemist Warehouse sells a dose, I think it's $120. So by the time you've had 3, it adds up. So that's the downside. And you know, most people don't bump into animals on a short trip to Bali. Well, unless they go to the monkey. I think the main thing is tell them, please don't be tempted to feed the monkeys at the monkey forest, because I think that's that's the thing that we see most. Yeah, I don't think, generally speaking, it's something you should be pushing unless people are particularly anxious or something like that.
Ellie just commented, is there a plan for more public health messaging around bats? So in terms of, like, you know, dead bats on local beaches and kids picking it up and not realising how dangerous it is?
So there certainly was. Look, I'm not aware of any specific plans. I think that the ministry is reviewing everything to do with bats at the moment as a result of this, and there was quite a lot of, I think, you know, there was the opportunistic media that occurred, and often we find that's, you know, the most useful thing, because there's the hook there and it focuses people's mind. I mean, interestingly, actually, just on that is, I was a bit worried that we might suddenly get a flurry of people suddenly realizing that they need to go and see a doctor when they had contact with a bat, and I don't think we have seen that, actually, which is interesting. So perhaps that's either because the message hasn't got out, or that perhaps people aren't, you know, it's not really common that people are getting bat contact.
Yeah. Any other questions? Feel free to unmute. But that was amazing. I love the smorgasbord of public health, and especially, lyssavirus is something that, yeah, it's there, but we don't think about it all the time. And I've certainly got a few patients that work with wildlife, saving, you know, animals that have been hit by cars, etc. So they've certainly had their rabies courses, but I've just remembered probably need to have their serology tested and a booster. So great reminders.
Can I just one other kind of interesting kind of interesting thing that I'll just mention. So one of the things that comes up apparently is that people wake up to find bats in their bedrooms. That's a story that is not uncommon. I think maybe more in colder countries, but that's quite interesting because it's a real test of one's risk threshold, or risk for bats. And in the UK, the guidance, and I think in many parts of the world, there's pretty clear guidance that if you wake up with a bat fluttering around your bedroom, even if you've got no idea that you had contact with it, you should get post-exposure treatment, just because the risk is there. We don't have any guidance along those lines. This is the sort of thing that I think that there's a little bit, the guidance in here is it's timely to update it, because I think there are all these little things that arise. But basically, I think for many of us, we have a very low tolerance of risk when it comes to bats. So please, if you do see anyone who's had any sort of interaction with bats, have a discussion with us.
And then Kat's just put in a link to a Australian General Practice article that she's an author of too. So very good. That was fantastic, guys. Thank you, and we'll definitely love to have you back again, because there's so much scope within the public health world and lots of topics that we'd love to hear about. So thank you, and I'll hand over to Cindy.
Well, thank you so much, Georgia, and I'll just say thank you to Richard and Kat, and I'm just going to stop the recording there.